Assalamu alaikum, good evening. Hello everyone, this is Dr. Muhammad Helmy, and I would like to welcome you all to this webinar. And this is the last webinar of this TOG week. I'm so glad to have you with me today in this webinar. So we mid-exam expert decided to make this week of TOG talks, which started with Dr. Zaib and the previous session was Dr. Muhammad Hassan. And this webinar will be the last one in this week. And as my dear colleagues, Dr. Zaib and Dr. Muhammad Hassan told you that maybe the policy of the Royal College in the past couple of years in the exam to bring more questions from these talks. So we decided to sum up some of these talks to you and to tell you what are the important points of these talks. That's not only the aim of these talks, but actually we also picked some topics which are very vital and important in our clinical practice. So besides preparing for the exam, we need to know this information for our clinical practice. In the exam, when we take any exam in our life, the aim of our journey is not only to run after a certificate or run after a title. No, we have to finish this exam, changing our attitude, changing our way of thinking, our practice to be evidence-based. So that's the most important task of these exams, not only just a title or a certificate. So it's very important to cover these topics and to read these topics, not only for the exam, but for the practice as we have mentioned. So today, our topic will be the early ovarian aging, one of the topics which was published in 2019. And one of the topics, I think, especially for those who are practicing the reproductive medicine and IVF, one of the vital points to know about the early ovarian aging. So before going through the session, let's start making some brainstorming. So I want you to discuss with me, I want you to share your opinion with me. So what do you think, what's early ovarian aging? I know maybe some of you have read the TOG article before, but let's discuss together before going through this short talk. What do you think is early ovarian aging? Can anyone reply? You can turn on your mic and tell me your opinion. What do you think from this title, early ovarian aging? What do you think, what's early ovarian aging? Okay, I got one response in the chat, but try to open your mic and talk. That will be better. Okay, Dr. Mona says that's failure of the ovaries to ovulate before menopause. Okay, I'm not going to say that's right or wrong. I just want to collect your opinion. Dr. Kenda, some women who are not responding well to ovulation induction. Okay, that's another opinion. That's very well. Okay. Any other opinion? Please turn on your mic and talk. We are discussing. That's better. That's how the information will be fixed in your mind. Any other opinion? Okay, so we have two opinions: failure of the ovaries to ovulate, and the other one is that the ovary is not responding well to ovulation induction. Okay, so we have another term. We have another term. I think you heard about it, of course. It's called the premature ovarian insufficiency, the premature ovarian insufficiency, or what's called the premature menopause or the early menopause. Do you think, is there a difference between early ovarian aging and the premature menopause or the premature ovarian insufficiency? Is there any difference? Yes, of course. So what is that difference? Don't feel shy, dear colleagues. Please respond in the mic. If you can, of course, if you have the facility, you can talk in the mic. You can unmute yourself and talk. So FSH may be normal in early ovarian aging, but just mildly elevated. Okay, that's one of the differences. Difference of age, presentation, along with symptoms. Okay. So from your answers, whether in the definition or in the, yes, the difference in the sufficiency, it's markedly elevated. Yes. So you are talking about, the clinical impact of both conditions. That's right. Okay. We are talking about the clinical impact of both conditions. But I want you to know that there are one vital difference between them. One vital difference between them. That premature ovarian insufficiency is a certain end stage. It's an end stage or a disorder in the ovary. I mean that when we reach the stage of premature ovarian insufficiency, we don't have a way back. We don't have a way back. But on the other hand, the early ovarian aging is an ongoing process. That's an ongoing process which is happening in the ovary until reaching the end stage, which is the premature ovarian insufficiency. So we can say that the early ovarian aging is the precursor, the asymptomatic precursor of premature ovarian insufficiency. And this brings us to the last question of our brainstorming. So why we are addressing this topic? And we address this topic because we need to know whether we can detect the females who are having early ovarian aging in their reproductive life to make some measures, whether prevention or management by any means, to save her chance for pregnancy or save her fertility before she reaches that end stage of premature menopause. So that's why we are addressing this topic. And that's why we have to put in our mind that we need to know what's early ovarian aging and how to detect it, especially when we deal with patients who are accidentally discovered that they have problems in their ovarian response or their ovarian reserve in their early life, and they don't know the implication of that decline in their ovarian reserve, and they are postponing pregnancy, for example, or still one of the female which still has no male partner. How can she deal with that issue? How can she save her fertility for the future? So that's why we address this vital topic. So reproductive aging is associated with a continual decline in the oocyte quantity and quality until menopause. So the ovary is in a continuous reproductive aging process. There is a continual decline in the number of the oocytes and also their quality by age until the female reach the menopausal state. But there is variation in this process between the females or between the different females. So that's the definition of early ovarian aging. It is a condition in which there is low ovarian reserve at a young age, that this female has some sort of low reserve, low number of oocytes, low quality of oocytes in her young age, with also accelerated loss of the ovarian follicles. Of course, that's normal in the reproductive life of the female, that there is a continuous process of ovarian follicles loss through each cycle. When there is recruitment of follicles, some follicles will grow, or one follicle will grow to the state of the ovulating follicle or the mature Gravian follicle, and the other follicles will become atretic. So that's normal in any woman, that there is loss of the ovarian follicles. But here in this condition, there will be accelerated rate in that loss. And this can be obvious in the early 30s of age. So that's what's meant by early ovarian aging. That can be implicated, as our colleague said, that the ovary will not respond well to ovarian induction, or after a while it will fail to ovulate. But these are the implications of the process. And it's estimated that 10% of women, and this percentage is very important to know, 10% of women will experience early ovarian aging, and this will result in a premature reduction of fertility. And as a consequence, there will be poor response to ovarian stimulation as a part of ART. There will be also increased risk of miscarriage. If even spontaneous conception occur, this woman will have a high risk of miscarriage, and also the long-term effects, because these women will reach premature menopause early. So this will affect her general life, the signs of general aging, and increase the risk of premature or early menopause and all its complications, like the cardiovascular risk, osteoporosis, and so on. In most women, usually the fertility decline from the mid-30s, and the follicles will start to be lost in a rapid way around the age of 37.5 years. And at this age, the cycle may have, or the female may notice some changes in her cycle, after that progressing to cycle irregularity and then menopause at 51 years. And that's in most women, that's in most normal women will experience. But early menopause, which can occur before 45 years, and this approximately affects 10% of women, it was suggested that this woman will have gone through a process of early ovarian aging. So that's how they defined the prevalence of early ovarian aging, by a retrograde diagnosis or retrograde estimation, that they found that most of these women, or most of the women who had early menopause before the age of 45 years, will have experienced this process of early ovarian aging. So that's the difference, the main differences between the early ovarian aging and premature ovarian insufficiency. And as I said, the early ovarian aging is the asymptomatic precursor to early menopause, or at the extreme end of ovarian aging spectrum, the premature ovarian insufficiency or premature menopause is found. So when we see the differences between them, and that this table is very important, we see that the prevalence of the early ovarian aging, as mentioned in the previous slide, is 10%, but the premature ovarian insufficiency is 1%. In the female having early ovarian aging process, she can be asymptomatic with regular periods, and the FSH, as you said, it will be normal or mildly elevated, and still she has a good chance of fertility, and she does not need estrogen replacement therapy. Because, as I said, it's still an ongoing process. But at the end stage of this process, there will come the premature ovarian insufficiency, or what's called before premature ovarian failure. And the patient will start suffering from oligo or even amenorrhea and other symptoms of estrogen insufficiency. We are going to find that the FSH is markedly elevated, more than 25 or 30 international units. She needs estrogen replacement therapy, and the chance of conception is very low, maximum 5%. And of course, we all know how is premature ovarian insufficiency is diagnosed. We have a strict criteria to diagnose premature ovarian insufficiency in a patient who is suffering oligo or amenorrhea for at least 4 months, plus an elevated FSH level more than 25 international units on 2 occasions, at least 4 weeks apart. And this is the definition supported by the ESHRI guidelines and also by the NICE guidelines. So that's the criteria of diagnosing premature ovarian insufficiency. But unfortunately, we don't have a standardized diagnostic criteria for early ovarian aging. And that's make its diagnosis somehow difficult. "25 is the cutoff, the main cutoff. Okay, FSH level of 25, that's the strict cutoff. Okay. In the practice, we follow the level of 25. Okay. In the practice, we follow the level of 25. But in the talk, they mentioned between 25 or 30, but actually it's 25. More than 25, it's diagnostic. But of course, we need to repeat that 2 times at least 4 to 6 weeks apart. There were some other terms like premature ovarian aging, occult primary ovarian insufficiency, or diminished ovarian reserve have all been used to describe the condition, but the term early ovarian aging may be more appropriate than premature ovarian aging, which implies a more advanced or severe process leading to POI, or the premature ovarian insufficiency. So, as the trend toward older age, first pregnancy continues, the clinical impact of early ovarian aging increase. And that's another reason we should know about early ovarian aging, because a lot of females now are delaying their first pregnancy. So some of them, about 20%, who are presenting with subfertility are having evidence of early ovarian aging. So the condition becomes clinically apparent only when the ovarian reserve declines to such an extent as to cause subfertility and shortening of the menstrual cycle. So we start to recognize early ovarian aging when the ovarian reserve reach a level that it causes subfertility or subabnormalities in the menstrual cycle. And also the markers of the low ovarian reserve, like raised FSH level, reduced the antral follicle count, low anti-Mullerian hormone, will only become apparent late in the ovarian aging process. That's why we have a difficult diagnosis of that process. And we need serial assessment of the ovarian reserve markers and comparison with age-matched normal values. So we cannot make the diagnosis of early ovarian aging easily by measuring the parameters once. We need serial measurements. to diagnose that there is abnormal decline or there is a fast decline in the markers of the ovarian reserve. And of course, we depend on the FSH level, the antral follicle count by the ultrasound, and the level of anti-Mullerian hormone. So what is the pathophysiology and etiology of ovarian aging? In the ovaries, there is, as I said, a continual decline in the number of oocytes. Actually, the ovary of a female fetus will reach the maximum number of oocytes at about 16 to 20 weeks gestation. And the ovary will contain about 6 to 7 million of oocytes. Then this amount will decline to about 1 to 2 million at birth, and until reaching puberty or menarche, the number will become 300,000 to 400,000, and some other references say up to 500,000 in that range. So the follicles are activated from the primordial follicle pool, progressing through the phases of follicle maturation until the dominant follicle or the ovulating follicle is formed. And at each stage of this growth of the follicle, other follicles will undergo atresia or become atretic. And through this continuous process of recruitment and atresia, there will be continual decline in the pool of the oocytes in that ovary or the primordial follicle pool. So that's a normal thing, the continual depletion or decline in the number of primordial follicles or the ovarian reserve in the female. And the accelerated loss will occur around 37 years, as mentioned before, until menopause is reached. And of course, the decline in the number of oocytes means that the level of estrogen will decline. And as a consequence, the level of FSH hormone will rise towards menopause because there will be no negative feedback mechanism. So the FSH will be secreted more from the anterior pituitary. This will lead to more follicle recruitment because FSH induce that ovulation. So there will be more recruitment of follicles, more decline or more decline rate or more loss rate of the follicles. So the cycle will be shortened, increase the multifollicular development. And so also there will be increase of twinning. That's why twin pregnancy may be common in old age, and an accelerated rate of follicle loss. And that's the normal ovarian age. Ovarian aging also affects both the oocyte quantity and also quality. And the oocyte quality will decline by 31 years. So that's why there is increased risk of aneuploidy and miscarriage with older age. And there are variety of mechanisms that are suggested to be behind the decline in the oocyte quality. The age-related genetic changes, the DNA alteration, mitochondrial DNA mutation, and reduced telomerase activity. By the way, what's the telomerase enzyme? Do you know? Can anyone answer? Does anyone know what's the telomerase?
Telomere, that will be effect on chromosome, something like that.
Yes, you got the answer or are so near to the answer. See, that's the DNA or the chromosome like that. At the end of the chromosome, there is a sequence of the DNA called telomere. And with the continuous division of the cell, this telomere undergoes continuous shortening until it's completely disappear. At that stage, when the telomere disappear, the cell will stop to multiply again. That's called cell aging process. But in the stem cells and the gamete cells, and also the same in the tumor cells, okay, there is an enzyme called telomerase. This enzyme is the one responsible for repairing this telomere to allow the cell to continue proliferating, to continue multiplying or dividing. So by age, this telomerase activity decline, and there is no generation or multiplication of the follicles or growth of the follicles at old age. Also, there are microenvironmental changes like increase in the oxidative stress, advanced glycosylation in the products, and glycosylation means binding of carbohydrates to proteins, and that's a normal mechanism which control the protein metabolism. But sometimes when accumulation of these products, this affect the DNA and protein inside the cell, and also impairment of the vascularization of the follicles. All these are changes which happen by age, which decrease the oocyte quality. So even if we have some number of oocytes, their quality is bad and fertilization fails. That's why sometimes fertilization completely fails, or even if it happens, we have abnormal zygote or abnormal embryo which contain some chromosomal abnormalities or aneuploidy or so. This will increase, of course, the miscarriage rate. So for early ovarian age, the hypothesis say that or suggest that early ovarian aging follows a model of follicle loss similar to the normal one. However, the onset of ovarian aging process occurs significantly earlier. So that's one of the early ovarian aging hypotheses, that it's the same process which happened in the normal female, but occurs significantly earlier. That's why she reached menopause earlier than the normal females. So we have certain number of follicles, and at certain age, there is an optimal fertility. After that, the fertility will start to decrease until reaching the end of fertility stage. After that, the patient will suffer irregular cycles. After that, reaching the age of menopause at 51 years. Also, the hypothesis accepted that in some studies that the decline in the ovarian reserve depends mainly on the size of the remaining pool of follicles and accelerate when the follicles become lower. So the more the follicles become lower in number, the more the acceleration process. So that's maybe another cause. So those females who are already born with small number or small pool of follicles, they have early ovarian aging and reach premature menopause earlier. Data also which came from the IVF studies have identified that oocyte number and quality, both of them are primary factors in the age-related decline in fertility. And they demonstrated that the decline or the rate of decline in the ovarian reserve is varying between individuals. It's not the same, it's difference between individuals. And the low ovarian reserve, as represented by poor response to ovarian stimulation, as mentioned by our colleague at the start, is associated with increased risk of premature or early menopause. So there is decline in both oocyte number and oocyte quality, and both are the factors affecting the age-related decline in fertility. The oocyte number, as I said, we have a fixed rate. That's the hypothesis, that there is a fixed rate of decline, but in early ovarian aging, it occurs in an earlier stage. But with the advancement of studies, they have said that this fixed timing hypothesis is like somehow oversimplification of the issue, because, as I said, there is a lot of variation in the rate of oocyte loss between individuals, as proven from the different studies of IVF. And the rate of follicle recruitments different between people, like 100 to 7,500 follicles per month. That's a very wide range of follicle recruitment. So of course, the rate of AMH decline between the individuals will vary. So there may be another possibility that those women suffering early ovarian aging may have accelerated follicle depression rate compared with the normal woman. And this was proven by comparing those women who have fertility problems and low ovarian reserve to those normal women who are egg donors. They have found that there is a steeper decline of the antral follicle count in the women with low ovarian reserve than the egg donors. And also the end of fertility stage to the menopause stage interval, that interval between the end of fertility and the menopause is short in those women having POI. So that proves that there is accelerated rate, that the process is happening so fast. They found that the median of that interval in patients with POI is 4 years compared with 10 years in normal women. So it is therefore not completely understood whether the early onset of ovarian aging is due to a smaller follicle pool at birth or due to an increased rate of loss. We don't know up till now. Is that an early process that happens early at life? Okay, or because of the female have a smaller follicle pool at birth, or there is increased rate of loss. But most likely there is a combination of these factors together. So there is a combination of these factors. A female may have a small follicle pool at birth. She may experience this process earlier in life, and there is an accelerated rate of ovarian loss compared to the normal woman. Am I clear so far?
Yes, clear.
Okay. And regarding the quality, the only factor which affect the egg quality or the oocyte quality is the age, is the female age. That's the only factor which affect, or that's the only surrogate marker of oocyte quality, is the female age. So, as fertility depends on both egg quantity and egg quality, women with early ovarian aging will have normal fertility when they are still young. That's in their early 30s. So we can say that the good oocyte quality may compensate for the oocyte quantity or the decline in the oocyte quantity. And that was also seen in young women who survived cancer, who have been exposed maybe to chemotherapy or radiotherapy. So of course, this can decrease the ovarian reserve, but they still have good fertility chances because they are still young in age and they have good oocyte quality. So we can say that in young age, the oocyte quality can compensate for the decline in the oocyte, the oocyte quality can compensate for the decline in oocyte quantity. And that's why the early diagnosis of early ovarian aging may be somehow difficult, because as I said, it's mostly asymptomatic in those young women. And the etiology of early ovarian aging is mostly multifactorial, like that of the premature ovarian insufficiency. I'm not going to talk in details about the causes of premature ovarian insufficiency because it's a very long topic, but we know that there are multiple factors, genetic factors, and that's the main cause behind early ovarian aging and premature ovarian insufficiency. Maybe some drugs, chemotherapy, radiotherapy, smoking, autoimmune diseases, infection, endometriosis, the in utero environment, some exposure to certain environmental changes in utero may affect the development of the ovary of the female. Maybe endocrine changes, maybe other changes which can affect the development of the ovary in utero, leading to birth of a female baby with already having low pool of follicles in her ovary. So the POI is the extreme end of the ovarian aging, and we can use it to study the etiology of early ovarian aging, as mentioned in the previous slide. And also, based on similar prevalence of genetic and autoimmune abnormalities, it has been suggested that POI and EOA, the early ovarian aging, share similar etiology. So now we know that we have the early ovarian aging process, which can end to premature ovarian insufficiency. We know that this may be because of accelerated rate of follicle decline, maybe due to low follicular pool at the ovary, or maybe due to starting of the aging process very early. All are these the hypothesis of early ovarian aging, and both of them, whether the early ovarian aging and premature ovarian insufficiency, are sharing the same etiologies. So what are the reproductive and general health consequences? What are the consequences of that problem? So why we are talking about this problem? Because of course it has a lot of consequences. The first one is subfertility, of course, and that's the main concern. But we have to know that the AMH levels are not associated with time to pregnancy. And several studies show no reduction in the fecundity rates in younger women with low ovarian reserve. But this is more noticed in older women or those who are moderately or severely affected, like when the FSH level are increasing more than 15 international units, then we can notice reduction in fecundity rates up to 50%. Why is it difference? As I mentioned before, because the quality of oocytes in the young women, even if they have early ovarian aging process, is relatively preserved, Natural conception remains possible, and success rates following ART are good. The second implication will be increased the aneuploidy rate and miscarriage rate. So in younger women with early ovarian aging, oocyte quality may be relatively preserved in comparison with oocyte quantity, but also data have indicated that there is increased risk of aneuploidy and miscarriage. And that was shown in some studies. When they compared young women with recurrent pregnancy loss, they found that aneuploidy rates are higher in the women or in the group who are having diminished ovarian reserve than in those who have normal ovarian reserve. So they brought two groups of women, both of them are suffering recurrent miscarriage rate, but one group has low ovarian reserve, the other group has normal ovarian reserve. They found that the cause of miscarriage was due to aneuploidy rate, higher aneuploidy rate, more in those women who are having lower ovarian reserve. And also from the largest observational study, which was done in the UK, after following up of 124,000 IVF pregnancies, they found that young women with poor response to ovarian stimulation, and that's implicated that they have some sort of low reserve and early ovarian aging, are having higher rates of miscarriage than those with a good response. Whether these findings reflect poor oocyte quality or could be due to other biases, such as an adverse effect from higher doses of stimulation in poor responders, remain unknown. So they don't know whether this high miscarriage rate in those women with poor ovarian response are due to poor oocyte quality or maybe due to the adverse effect of higher dose of stimulation, because such women who are considered poor responders, we need to give them higher doses of ovulation induction therapies. So maybe the miscarriage rate is due to the side effects of these therapies. So up till now, they didn't clarify what is the main etiology behind that higher rate of miscarriage. So the first thing, subfertility, which is more noticed in the older women or when the FSH levels start to rise more than 15 international units. As in young women, the oocyte quality is somehow preserved, which compensate for the quantity, but also despite having good oocyte quality, and so they found that these women, even if they have young age, they have higher rate of aneuploidy and recurrent miscarriage. Also, it has been suggested that when they compared some women who have early ovarian aging and miscarriage, women who have early ovarian aging and miscarriage and other women who have miscarriage but they don't have early ovarian aging, they found that the miscarriage rate are higher in those women who have early ovarian aging, even if the cause is not due to aneuploidy. And this may also indicate that there is an underlying autoimmune etiology in early ovarian aging. So even those women who have miscarriage and they have early ovarian aging process, and they found that, or they discovered that the miscarriage is not due to aneuploidy, this means that there may be another cause of miscarriage, which also may be the underlying autoimmune etiology in the early ovarian aging. So if they escape the aneuploidy problem, they may have an underlying autoimmune problem, which also can cause miscarriage. The next consequence is, of course, the premature ovarian insufficiency or the early menopause. And that's the extreme end of early ovarian aging. And a 10-year follow-up of women under 40 years who have had a poor response to ovarian stimulation during IVF showed that 11% of them developed early menopause and 3% developed premature ovarian insufficiency. So the follow-up of these women who have poor ovarian response due to early ovarian aging, they found that these women reached menopause earlier. 10%, 11% developed early menopause and 3% developed premature ovarian insufficiency. And because of that, there is much interest in the use of ovarian reserve markers to make individual predictions about the age of menopause. They now want to use these ovarian reserve markers not only to wait until diagnosing premature ovarian insufficiency. No, we want to predict that this case can reach menopause earlier. And they found that a lower age-matched AMH and antral follicle count are associated with earlier age at menopause. Those women, AMH and antral follicle count, they can reach menopause at earlier stage. But the present models of ovarian reserve tests are limited by the variability between individuals, and there is also lack of accuracy. So we cannot predict the age of menopause based on a single ovarian reserve marker. As mentioned before, we need to do serial measurements. Serial assessment that consider individual variation in the rate of AMH decline can enhance the prediction. And not only that, we have also to include the family history. The family history is very important. So when you have a female who tells you that her mother, for example, reached menopause at the age of 40 or 39 or 41 or 42 or whatever, so you have to predict that she can be the same as her mother. There is some sort of heritability in this condition. So incorporating the ovarian reserve markers plus the family history can improve the predictions from an early age. The next implication is the general aging process. And of course, we know that the premature menopause and the premature ovarian insufficiency may be associated with decreased life expectancy, decreased quality of life, increase in the cardiovascular risk, increase in the osteoporosis, and so on. And also they have found that the low ovarian reserve can be associated with adverse cardiovascular risk profile, and also higher FSH levels are correlated with increased risk of hyperlipidemia and atherosclerosis. And all of this is mostly due to the estrogen deficiency state. And there were some studies also that found a correlation between the rate of decline of AMH and the incidence of cardiovascular disease. And that was independent of the menopausal state and even the metabolic risk factor. So you can expect that those women who have a rapid decrease of the AMH hormone level, they may have increase in the incidence of cardiovascular disease. Some studies have investigated some genes at the age of menopause, or those which affect the age of menopause. And those genes which affect the age of menopause are mostly genes which are involved in the DNA repair process and genome stability, which is of course linked to the general aging. I mean that there are some genes which control the DNA repair and genome stability. They are related to identification of the age of menopause. So some of the authors challenge the traditional belief that the early ovarian aging lead to the general aging process in the female. No, he believes now that the ovarian aging process may be a part of the general aging caused by accumulation of DNA damage. And that's the reverse, okay? So they were suggesting that the ovarian aging will lead to the general aging implications. Now they thought that maybe the general aging process itself and the DNA damage and so on cause general aging, and a part of this general aging, it will cause early ovarian aging. So that's also another hypothesis about early ovarian aging. Am I clear so far?
Yes, clear.
So, how to manage? Sorry? So again, before proceeding to the management, that early ovarian aging can be associated with long-term health consequences. But as I said, it's not yet known whether this represents the effect of reproductive aging or whether women with early ovarian aging have an early aging phenotype that also affects the ovary. So as I said, we don't know, is the early ovarian aging is behind these long-term consequences, or the female herself has an early aging phenotype in general, and also this will affect the ovary. So how to manage this issue? First, and most importantly, the most important concern is the fertility, of course. And we know that women with early ovarian aging can still have good reproductive potential because she still have a pool of follicles and still she has preserved quality, especially if she is at young age. So in women with sufficient ovarian reserve who are ready to start a family, natural conception remains an option, although early investigation for other causes of subfertility is recommended. That's why we have to start concerning about the early ovarian aging now. And that's very obvious in the fertility practice. Because sometimes a woman comes to you after, like, she's very young and she is married like for 6 months, and that's considered for the fertility, it's a short interval. We don't get afraid or worried if a woman passes 6 months without pregnancy, and that's not an indication to seek other investigations, right? But sometimes when you take a history from her and you know her family history and so on, you may suspect that in that family there is some sort of this process of early ovarian aging and premature menopause. When you do some investigations, you found that the AMH level is somehow low, FSH is somehow high, okay? So you can suspect from this that this woman is not normal at this age. That's not matching with her age. So you have to be here more careful. Yes, you have she has a chance of natural conception, but at this time you have to be more careful. You have to be like, you know, suspecting that this female will not be like other females or other normal females. So we have to search for other causes of subfertility first to exclude other causes of subfertility. And if you don't find that, you have to counsel her about that investigations, and these investigations must be repeated. And if you find that these investigations are declining or are deteriorating, then you cannot hear or at that stage counsel her to wait for other women like 2 years and then start to take fertility treatment or so. Now, no, you have now to counsel her that she should take a step forward. She have to make another plan. Whether she is married and she's searching for pregnancy, or if she comes for investigation and she's still single and she doesn't have a male partner, she may search for other methods for her fertility preservation, as we are going to talk in a while. Of course, IVF is most commonly employed treatment strategy in such cases, but its efficacy over the expectant management or intrauterine insemination has not been subjected to randomized controlled trials in that group of females who have early ovarian aging. They still have ovulation, they have still ovarian reserve, good ovarian reserve, but there is no studies have done between or comparing between IVF and expectant management or intrauterine insemination at that group of women. But of course, in cases of extremely poor ovarian reserve, now we have reached the stage of POI, egg donation is usually recommended. Also, the increasing success rates associated with oocyte freezing have provided a further option for women not yet ready to start a family. Those women who are not ready to start a family, or she is not having a male partner, she may consider oocyte freezing, which is now no longer considered an experimental treatment. That's an established treatment. It's done in many centers all over the world now. And the live birth rate per treatment cycle in the UK is currently around 18%. So it's now an established treatment modality of oocyte freezing. So the female who is not ready to start a family, or she is not having a male partner, she may consider oocyte freezing. Regarding ART, now this woman decided, for example, to go through the assisted reproduction and going through IVF or XC or so. What is the best stimulation protocol, and what are the expected success rates? Despite having lower response to ovarian stimulation than average, their prognosis is still good, as I said, the oocyte quality is somehow still preserved. So that increased the chance of the ART success. And the IVF outcomes in young women with early ovarian aging is significantly better than older women with similar levels of ovarian reserve. And that's because of the oocyte quality. Do we need to do mild stimulation protocol or standard stimulation protocol? Means to give them mild doses or to give them the standard doses. Actually, and I'm talking about the practice, when we deal with older women who have decline reserve or a decline in their reserve, and that's normal because they are old, they have primary or secondary infertility. For example, one woman comes to you at 35, 37, or 39 years of age, even if she has a normal ovarian aging process. But of course, at that age, you might expect that the reserve is low. So at this stage, even if you give high doses of ovarian stimulation, you will get the same result. So in such cases of women, we usually give them a mild stimulation protocols, because we do not expect more than like 1, 2, or 3 maximum as a number of oocytes or so. But when they did a comparison between the women with early ovarian aging, the young women with early ovarian aging, they found that these women can benefit from increased stimulation dose, not mild dose. So you can increase the dose of stimulation in young women with early ovarian aging. Agonist or antagonist protocol, it's according to the protocol you prefer, okay? But usually in the poor responders now, the antagonist protocol is better. The antagonist protocol is better because agonist protocol, especially the long agonist protocol, cause more suppression. You don't want that suppression. You might choose the short agonist protocol or the flare-up agonist protocol, or we can go better for the antagonist protocol. That's for poor responders, of course. Clear? Okay, so not to get lost again, fertility chances or natural conception chances are still found in those women with early ovarian aging. But of course, the way of counseling and the way of follow-up will differ from those average females. That's the first one. When we want to intervene with her, we mostly go through the IVF or the assisted reproduction. And of course, in severe cases, we need egg donation. In some, of course, countries, that's egg donation, of course, is not acceptable in all policies and all religions. But of course, in some countries, it's accepted. And of course, they do egg donation. And when we start the ART cycle, we expect that the young woman will have better IVF outcome than the older woman because of the preservation of the oocyte quality. Plus, those younger women can benefit also from higher doses of stimulation than the older woman. Is there a rule of adjuvant therapies in these ART cycles? The only drug that proven to have some benefit, which increase the clinical pregnancy rate, live birth rate, and also reduce the miscarriage rate in those women who have low ovarian reserve, the dihydroepiandrosterone dione. The dihydroepiandrosterone dione. Of course, we have a lot of adjuvant therapies which have been studied in the field of ART, like giving a low dose aspirin, the calcium, the growth hormone, the dihydroepiandrosterone dione, and so on. But the only drug which have proven of having some benefit, and of course, that's plus the antioxidants, the dihydroepiandrosterone dione. Other adjuvants have been studied, but there are lacking of high quality randomized controlled trials, and no single treatment has consistently been shown to improve outcomes in women with low ovarian reserve. So the only one which have shown to be of some benefit is the dihydroepiandrosterone dione. For the long-term health, you know, when a female with subfertility who comes to you for this concern in particular, and you know that she has some sort of early ovarian aging and poor ovarian response, okay, and you managed her with IVF treatment and she got pregnant, and so that concern is over. You don't have to let her leave your clinic before you counsel her about the remaining reproductive health. So yes, we have solved one issue, which is fertility, but still you have other problems. So you have to be educated about seeking advice very early when there is some sort of menstrual irregularities or menopausal symptoms, because this female is at increased risk of a lot of problems due to the early menopause, like said before, cardiovascular osteoporosis and so on. So that's also an issue which should be addressed. So ideally, they should be followed up in specific clinics to help manage their risk of cardiovascular disease and osteoporosis. And this involves risk factor assessment combined with lifestyle and dietary modification and consideration of hormone replacement as they reach the menopause. So all of this should be addressed. She is not only coming for you for fertility. Yes, that's maybe her only concern because she is not well educated about this problem, but you have to when you solve this problem, first problem is, which is fertility. Now we have to address the other issues. You are not like the average females. You have to be careful that you might reach menopause earlier, and this can have some implication on your general health. So is there a way, or is there a rule for screening for early ovarian aging? That's why we are addressing this topic, okay? Like when we have in oncology, we have some precancerous lesions, and then we have the cancer. Now, all the target of most of the recent research is to screen for the precancerous lesion, because we don't want to reach this final stage of cancer. That's the same issue here. Of course, the difference is, of course, there is great difference between the two, or the severity of the two conditions, of course, but the screening here is very important. Is there a way to catch these women in that age, in that early ovarian aging process, before they reach the premature menopause, to save their chances for pregnancy, to save their chances for fertility before reaching this end stage where no way back again? So there should be informed reproductive counseling, especially when you suspect that this woman has some sort of poor response or poor ovarian reserve. So there should be informative reproductive counseling at this stage. And earlier diagnosis of early ovarian aging will allow women greater autonomy to plan parenthood with more available options. Because the more she waits, the lesser the options she is having. The more she waits, the lesser the options she is having. So we can start screening of high-risk group, those who have subfertility, or they show poor response to ovarian stimulation, or having a family history of early premature menopause, or they had a history of ovarian surgery or treatment for cancer such as chemotherapy or radiotherapy. So we can start screening of these high-risk groups, and to do this serial monitoring of the ovarian reserve testing, like the antral follicle count, the anti-Mullerian hormone, and the level of FSH. Although the authors say that screening should be applied to all healthy women with no risk factors for low ovarian reserve, which should commence at the age of 25 to 30 years. Some authors suggest that all women should have some sort of screening or to do some investigation at that age. Of course, this is not applicable to all, but by time and by increase in the awareness, those females who are delaying pregnancy, or still they are not having male partner, at least they can go for checkup and know if they have some problem or not in their ovarian reserve. Of course, the screening should be done through the ovarian reserve testing, like anti-Mullerian hormone, antral follicle count, FSH, and comparing them with the age-matched normal reference range. Some studies have made data demonstrating the age-related normal values of the AMH and antral follicle counts, which make screening of the early ovarian aging somehow feasible. And of course, the most important of these reserve markers is the anti-Mullerian hormone, because it's the earliest and most reliable marker of a decline in the ovarian reserve, because this might be a site of question. What is the earliest and most reliable marker of decline in ovarian reserve? It will be the anti-Mullerian hormone. But we have limitations of this ovarian reserve test. The first thing, that they act as a surrogate marker for oocyte quantity rather than quality, because we know that the only factor which determines the oocyte quality is the female age. So they are just markers for the quantity, not the quality. And as I said, quality somehow can compensate for the decline in the quantity. Also, the FSH hormone shows significant intercycle variability, and it's a late marker of low ovarian reserve. It starts to rise late. So we cannot depend on FSH measurements in different times of the cycle. We have to unify the time of FSH measurement, and usually we measure it basal on the second or maximum the third day of the cycle. the antral follicle count also considered relatively having higher cost because we need to do ultrasound and also inter-observer variability. When I do ultrasound, it's not like when my colleague do an ultrasound. We may like count somehow different from each other. That's somehow inter-observer variability. Also, the AMH is not as stable through the menstrual cycle as previously thought, especially in young women, and it is affected by many factors, biologic, reproductive, and environmental factors like hormonal contraceptives and ethnicity. So we know that AMH is somehow stable through or somehow the same level through the menstrual cycle, but not that strict stable. There are also some variations, not sharp variations, but still there are some variations. And we don't have yet a certain cutoff value of AMH, which can diagnose early ovarian aging. And also there is a great problem in that issue of anti-Mullerian hormone, the differences between the assays and different laboratories. And I think if you ask one patient to do the anti-Mullerian hormone level in 3 different labs, you are going to get at least 2 different values from these 3 labs. That's why, because there are many assays of this hormone that make the comparative studies challenging. Because if you want to make a large scale study, you want to make sure that all the labs which are involved in this study are using the same way of measuring the hormone or the same assay or so. So that's what make the studies somehow challenging. So because of this variable rate of follicle decline, a single assessment of ovarian reserve may not identify those with early ovarian aging. Therefore, again, serial testing to provide information about the rate of decline of ovarian function is required. So now I don't want one measurement. I want to know what is the rate of decline. What is the rate of decline? So if I have a woman with anti-Mullerian hormone of level like 2, for example, and after 6 or 7 months, I found that the level started to decline to 1. After that, it became 0.9, 0.8, means that there is a rapid decline rate. This means that this woman is in a state of early ovarian aging, and she might reach the stage of premature ovarian insufficiency earlier. So, as the author said, all women should have to screen themselves at the age of 25 to 30 years to detect this process. There will be, of course, disadvantages. Why? Because this, of course, can have some negative psychological impact, causing significant anxiety, despite not necessarily being able to accurately predict immediate fertility potential. As I said, yes, she might be a young woman who have somehow low reserve, but her quality of oocytes is good and her fertility chance is still preserved. So she might be under stress when she knows that she has some sort of low ovarian reserve. And of course, the financial burden of treatments such as egg freezing. So because sometimes a woman who is still young at age, she doesn't have a male partner. When she knows that she has like some sort of low ovarian reserve, she might go for egg freezing, and this can have some sort of financial burden on her. Also, the normal result may be counterproductive. You may get normal result, but this can give a false reassurance. And this woman can safely delay conceiving until much later in life, and this can have a negative implication on her reproductive life. Also, to screen for a certain problem, you have to study the economic and public health effect of screening for such problem. So it's still controversial. When we screen for any disease, we need to know first, what are the economic and public health effect of that disease? And is it worthy to screen for it, or it will not cause any significant change in the outcome? So still, this is some early issue to confirm, and still there are more studies to be done in that issue. Assess the early ovarian aging in clinical practice, and that was mentioned before, but again, we have to say that we need risk factor assessment via the medical history combined with the ovarian reserve testing. But as I said, we cannot depend on one or single measurement because of the variability and the standardized age-matched normal reference range for these tests are not easily available in daily practice. The problem is that at present, up till now, most women with early ovarian aging are only diagnosed relatively late at the onset of moderately abnormal ovarian reserve tests, such as FSH value of 10 to 20, antral follicle count below 4, and anti-Mullerian level below 5 picomoles per liter. Women younger than 37 years. So that's the issue, that most of them are diagnosed late. And all the concerns now and all the modern researches now is done in a trial to catch these women at earlier stage. So the key message to women with early ovarian aging is that while they are young and asymptomatic, they retain good fertility. Nevertheless, this will decline at an earlier age than normal, and they may enter menopause early. So that's the key message you have to give to these women. Yes, you are young. Yes, you are asymptomatic. You still have good fertility chances, but this can decline earlier, and you may enter menopause earlier. So they should be educated about reproductive health and the effect of this reproductive aging on the conception rate. So they should be counseled about, and that's very important now, to avoid delaying pregnancy if possible. About the misperception that IVF can overcome the effect of age and low ovarian reserve, because some women think that IVF is the solution of everything. They don't know that the maximum success rate of IVF in young women without any abnormalities is like maximum 65%. They think that IVF success rate is like 100% and it can overcome any problem. No, they have to learn that this is a misperception. And they should know about fertility treatment options like egg or embryo freezing, or treatment with donor sperm for single women. If she is single and she wants to get a baby, of course, in those countries which allow donor sperm, she can have this option. So when you have a case, you suspect that she has some sort of early ovarian aging, or she has some sort of subfertility, or she wishes to consider fertility preservation, you have to refer this woman to a fertility specialist. And although there is no evidence that women with early ovarian aging who are trying to conceive should commence fertility treatment immediately, referral to a fertility specialist for investigation is reasonable in women who have been trying to conceive for 6 months or more, or even sooner if other infertility factors at present. So now the general rule of infertility won't be applicable here. If you see that this woman has some sort of early ovarian aging, she's trying to conceive for 6 months or more, no success in that, she should be referred for a fertility specialist. So she might start her fertility treatment earlier. We cannot wait for her, because the oocyte pool you are seeing now and the oocyte reserve you are seeing now, you might not see after 6 months or after 1 year. So you must have to take like a rapid action in such situations. Also, if a woman wish to consider oocyte cryopreservation, she should be done as early as possible, preferably before the age of 35 years. Why? Because we want to cryopreserve good oocytes with good quality, because the more the age, the lesser the quality of the oocyte. So if a woman wants to preserve her oocytes, this should be done earlier at age, before 35 years of age, to gain good oocyte quality. The last point we want to talk about is if there are preventive measures or maybe future treatments. All of these are like, under trial or under research. And first, before thinking about prevention, the Royal College addressed that all health professionals should take opportunities to educate young couples about the effect of reproductive aging and highlighted the need of fertility education to be incorporated in schools. And that's what I personally do in my practice. When a couple come to my clinic, they are recently married, but the woman is coming asking about some sort of contraception because she doesn't want to get a baby at this stage. I counsel her first to make some checkup to make sure that everything is okay with her and her partner before deciding to delay. Because if I notice any abnormality in her lab investigations or even in the semen analysis of her male partner, we might decide something different. They might be afraid of delaying and they might change their mind in that situation. There are some trial treatments to slow the ovarian aging process or at least to restore the lost ovarian function. This still might be, some are under experiments. Of course, the pharmacological methods like using of antioxidants, such as what's called the coenzyme Q10, one of the antioxidants, and the resveratrol. These are antioxidants which can reduce the oxidative stress. Maybe this can slow the process of ovarian aging. Sometimes they do what's called in vitro activation of primordial follicles. They do some tissue vitrification in the lab, and after that they do some activation of these primordial follicles in the lab and then retransplant this ovarian tissue again. This might restore the lost ovarian function. Also, there were some experiments about the therapeutic role of anti-Mullerian hormone to give the anti-Mullerian hormone as a treatment or as an adjuvant treatment, because we know that the anti-Mullerian hormone is one of the hormones which control the folliculogenesis process, or to do transplantation of ogonial stem cells into the ovaries, or the mitochondrial transfer to overcome the effects of declining oocyte, that they bring an empty egg without nucleic acid from the mitochondrial donor, okay, with the nucleic acid material from the mother, and of course the sperm from the partner, and this is called mitochondrial transfer. Of course, a lot of these modalities are still under experiment, and of course it's not in the regular practice, of course, of fertility. So to sum up the key points of that talk, the early ovarian aging refers to a condition in which there is low ovarian reserve at a young age and accelerated loss of follicles in the early 30s. It affects 10% of women, resulting in early onset subfertility, combined with an increased risk of early menopause and long-term cardiovascular effects. The past decade has seen a greater understanding of the age-related normal values for markers of ovarian aging, and so we are better able to identify women with early ovarian aging. Increasing success rates associated with oocyte freezing have provided a further option for women not yet ready to start a family, and therefore screening for early ovarian aging has become a viable option. Screening, even for those women who are not having a family yet or still single, they may have screening to consider oocyte freezing if they have some sort of early ovarian aging. Data shows significantly better IVF outcomes in young women with early ovarian aging than in older women with similar levels of ovarian reserve. And as I said, that's because of the better oocyte quality. Meta-analysis has shown that the benefit of the hydroepiandrosterone on IVF outcome, which improve the clinical pregnancy rate, live birth rate, and reduce the miscarriage rate. So these were the main points. And by this, we come to the end of our talk. I hope you enjoyed it. And if you have any question, I am listening.
Thank you.
Help you, inshallah, to pass the 3 steps of MRCOG easily, inshallah. Thank you so much.